This is Ethics Lesson 3. In this lesson, we're going to talk about the rights of the patient. We're going to talk about the myth of patients actually having a choice and meeting these patients' individual needs, evaluating our treatment successes. We're also going to discuss confidentiality, and then we're going to break down confidentiality and include what is our responsibility to confidentiality when child abuse issues arise. We're going to talk about mandatory drug testing, and we're also going to talk about AIDS in this lesson. So let's jump right in. A major and unique problem in the field of counseling chemically dependent people is the status of the patient. Most treatment facilities are going to maintain that their patients are there voluntarily and they've given informed consent to both the treatment and the release of the information. And this is often nonsense. It may be true that the patient has not been legally committed to treatment and that the doorknob turns from the inside and that anybody can leave at any time. And it may be equally true that if the patient does leave, they may lose their job or a professional license or the custody of their children, and sometimes a jail sentence will result. Unlike the committed mental patient with a host of safeguards and legal regulations, the addict is not supplied with that legal counsel and an outside physician advocate, nor does the institution have to show that meaningful treatment is even being provided. While some states can and do commit patients for addictive illnesses, many don't. Even in states where this is legally possible, most patients are still treated in what are called voluntary settings. People are forced into treatment in a variety of ways. Very few arrive without some sort of outside pressure. Clients may sign away their confidentiality safeguards under duress or while still so toxic that they're unable to appreciate the consequences. And we live in a society that tries to solve many social problems by passing increasingly strict laws. We build more jail cells and increase the severity of the penalties. Mandatory sentencing is stylish, and there's an increasing outcry to get impaired drivers off the road. And once an impaired driver has been caught, something more must be done. If this is not just careless misbehavior, and the real problem is alcohol or drugs, doesn't it make sense to mandate treatment as an alternative to or in addition to punishment? So where and by whom is it going to be given? What's the role of the state in deciding who needs treatment, what treatment is, who's going to give it, and who's going to make money from it? One hopes that the patient will be the one who benefits, but politics play a big part in that decision. Individuals with drug dependency problems are still not seen by the public as people whose rights must be defended. Not every state licensed treatment agency does a good job of caring for its patients, and some agencies actually do harm. This is a situation that may well get worse before it improves. So can we do without the coercion? Probably not, unless we're willing to stand by and watch a lot of people die as we did in the past. Addiction is characterized by denial and self-delusion. Initially, patients may be no more capable of making well-reasoned and informed judgments on their own behalf than small children. For a time, particularly in early treatment, the responsible therapist must accept that the patient is not able to make good decisions and that a little bit of creative coercion and outside pressure is not entirely bad. But how long does this situation last? How valid is that signed consent for release of information when it's obtained under duress? What does the demand to cooperate with treatment or lose a job or a license really entail? Since real mental impairment follows heavy use of alcohol or drugs, and since the treatment facility may have been given that patient even more drugs, that affect their judgment, maybe in detox, for example, how valid is that written consent? Now, my supervisor in the past has said that there are no volunteers. There's always someone who's pushing that client to come into treatment, whether it's their job, their probation officer, maybe a loved one. Um, there are no volunteers in this, unfortunately. And they may come into the treatment and feel like they have no choice. And they have to do this, otherwise their life is going to fall apart, or they're going to lose a relationship, or they may go to jail. So how voluntary is this treatment? Now, we know from research done by Nora Volkow, the president of NIDA, she said that the treatment outcomes can be just as good for those who enter treatment voluntarily as those who enter involuntarily, just because of the fact that they were exposed to the information in the first place. But that's not what we're talking about here. We're talking about the fact that there is no real voluntary admission to treatment. So counselors and other treatment professionals and law enforcement agencies, they're in this position of tremendous power. There is an unavoidable and probably acceptable situation if what is being done is in the patient's best interest, obviously. But when the decision makers are ignorant or incompetent or self-serving, the risks are obvious. Potential conflicts of interest abound. Although the true situation may be disguised on paper, the person who forces a colleague into treatment may be the very one who runs the treatment program the patient's attending. Sometimes the patient has no choice as to where to go or what kind of treatment to expect. And this is clearly dangerous. If people are forced to accept unwanted treatment for their own good, they should experience as little deprivation of freedom as possible. The person choosing the treatment facility should have no opportunity to profit from it in any way, including by financial gain, or by an increase in personal status, or by trading favors. There should be no conflict of interest, overt or concealed, real or apparent. So, one way that this problem has been approached, if never perfectly solved, follows this time-honored medical tradition. Once a problem has been defined and the decision made to refer a person for treatment, they should be offered a choice of acceptable treatment facilities, if possible. This should be a free choice situation, not just handing them a list of several alternates with a covert message that if the reference preference is ignored, somebody's going to be angry or retaliate. It's tempting for an employer or maybe a professional society to enter into some sort of contractual arrangement with like a single treatment facility. And staff can learn to know each other and work together smoothly. Cost arrangements can be adjusted to reflect that large volume of referrals, and beds can be made available when they might not otherwise be available, or they might be hard to obtain. It seems efficient, maybe simple, and very tempting. A worrisome development is the entry of employers and unions into the business of providing treatment for their own employees. So faced with the soaring insurance costs, and often located in communities that failed to provide outpatient treatment services, both groups have begun to set up their own programs. They're less expensive than the residential care, and they're probably going to demonstrate good treatment outcome results, since a lack of financial incentives have in the past resulted in much unnecessary residential treatment. The problem is that not only are employers now forcing patients into unwanted treatment, but diagnosis and treatment are both being decided on by fellow employees. And this can result in not only the risk of suboptimal treatment based on budget considerations, but also possible gossip and unfairness in treatment requirements, and to the same in-house jealousies and politics. The risks are obvious. The legal and the ethical implications might be a little less so. So treatment for chemical dependency needs to be as individualized as it can for all the other illnesses. So no particular treatment facility is the best place for every patient. Different facilities have different strengths and weaknesses. Some are particularly good for women, some for older people, some for youngsters, some for racists. Some offer excellent programs for family members. Some offer good medical or psychiatric care in addition to their basic treatment program. Some of them may specialize in pain management. Some are short term and others are extended stay. The list of possible differences is so long and so vast. Not only do facilities differ, but most show changes in the quality of care they give at different times. Treatment is going to often reflect the personality and the convictions of one or more highly individualistic leaders. So when staff members change or when they go through periods of not relating well to one another, the patient care could suffer. Resources need to be checked intermittently to be sure that the quality of care at any given treatment facility is acceptable. Whenever most of the referrals from a particular employee or organization are sent to the same program or treatment facility, that situation needs to be carefully scrutinized. It's unlikely that treatment's being tailored to the needs of each individual patient, and there's a risk that a bargain may have been struck between the referral source and the treatment agency. Until recently, healthcare providers were rarely asked to justify treatment costs or to demonstrate their efficacy. So, to be ill and in pain was considered enough to establish that person's right to treatment. Even if the effort to help proved inadequate, there was an agreement that it should be made. Alcohol or drug problems were regarded differently, though. Government policymakers and the insurance carriers have constantly demanded objective research to prove that treating addiction is both successful and cost effective. Employee assistance programs are constantly asked to point out savings in absenteeism, accidents, and property damage when chemical dependency is treated. While the obese person's diabetes and the heavy smoker's chronic bronchitis or emphysema and circulatory problems are covered by insurance and treated without question. Not only are the employees expected to demonstrate to employers that chemical dependency treatment is deserved, but the treatment agency is also expected to prove to employers and insurance carriers that their treatment works. There are good reasons to track and justify treatment results. On the whole, addiction treatment results are respectable and encouraging. So, in an age of increasing worry about the cost of healthcare and the inevitable need for rationing, it's increasingly important to have research data in hand and to have some experience in collecting it. We're too often presented with research that's little more than a treatment agency's bragging about its program success. Obviously less convincing than evaluation by a disinterested and objective outsider. Sometimes the results are clear and accurate and useful, but they might also be sloppy or misleading and possibly even invented. And if we're to retain that credibility and share useful information with one another about what works for the patient and what does not, we need to insist on quality data and well-defined goals. We also need to distinguish fact from philosophy. So, for example, there's an ongoing quarrel over the efficacy of methadone maintenance programs for heroin addicts. Some people, especially those in the chemical dependency field, argue that the primary treatment goal must be a drug-free lifestyle. Others familiar with the street scene argue that while abstinence may be the ideal, indefinite methadone maintenance is the lesser of two evils when the amount of violent crime perpetrated by actively using heroin addicts is examined. It's also worth mentioning that only a relatively small group of conditions have ever really been treated with painful electric shock therapy or inappropriate lobotomy procedures or some other type of punitive method. These also include homosexuality and child molestation, or even castration has been proposed, and then follows chemical dependency. Stigma has been and is still a major problem. And when society is particularly outraged and judgmental about certain groups or behaviors, we need to be alert to the difference between treatment and punishment under the guise of treatment. For many of the issues that are raised in this particular course, there's no easy answer. But we can insist on strict accountability, honest self-appraisal, and accurate reporting of treatment goals and results rather than rhetoric and opinion. The scandal is not that there are different approaches to measuring success, but that there hasn't been enough objective outside long-term evaluation of the treatment methods. We may have a tendency to overlook facts that do not reinforce our preconceived, emotionally derived opinions. We would also do well not to exaggerate the number of chemically dependent people in society. We don't need to argue that we're always in a new crisis or suffering some new epidemic any more than we need to pretend that one treatment method has all the answers for every patient. The truth about drug problems in our society is serious enough. It doesn't really need to be inflated. The misery caused by alcohol and other drugs is more than enough to keep us busy for a really long time to come. The ethics of professional confidentiality are going to bring up a host of complicated issues. The basic principle is that private information divulged by the patient in the course of treatment may never be used or repeated in any way that can be identified with the patient. So this allows for research and for generalized statements, providing that they don't stigmatize all the clients of a given facility. Note that I say private information because sometimes the counselor may also know the facts from another source, even a public one. So professionals must not reveal any information, including the fact that a particular person is a patient in a treatment facility without first obtaining their written consent. And this is while the patient is rational and drug-free. If this consent is not obtained, professionals may not share that private information, not even with a trusted colleague or a spouse. This is true if the counselor sincerely believes that the patient would be helped by the disclosure. Privileged communication is a legal term, and it refers to the practice of excusing many professionals, like physicians, nurses, clergy, psychologists, and others, from being compelled to testify in court. States vary as to which professionals are included. Addiction counselors, unless they happen to also belong to a profession named in a statute, usually must testify under a subpoena, which is a summons to appear in court. In some states, these legal exclusions also apply to someone whom the patient reasonably believes to be a licensed professional, which could include a counselor. The privilege can be waived or claimed only by the client or the patient. And even when the patient has waived that legal right, the professional may still have an ethical obligation to protect the patient's best interests. So regardless of legal privilege, professionals are ethically obliged to respect the confidentiality of the patient. So an implied contract or promise always exists. But it's never absolute. Exceptions can occur, and we may be obliged to violate confidentiality by informing maybe an intended victim or the police when there's clear or imminent danger of serious harm to our patient or another person. That's the CFR 42, part 2. We want to note that the danger must be clear, not vague, and it needs to be imminent, not just merely possible, and it must be of serious harm, not minor or merely inconvenient. And then we have professional consultation. And when we do this consultation about a difficult case, it is allowed, but the consultant is equally bound to confidentiality. Both ethics and federal law provide for the right of the counselor to consult an attorney or a doctor for maybe a medical emergency, but neither provides for a warrant that allows drug enforcement officers to hunt suspected addicts. Some statutes accept homicide and malpractice cases as instances where disclosure of confidential information is allowed. Another exception is in the case where the patient's purpose in disclosing information was to seek advice in the furtherance of a crime or fraud. So staff policy manuals should really indicate these exceptions, and the patient should be informed. And there's a host of other confidentiality concerns, like clerical staff needs to be instructed about the confidentiality of records and correspondence. Volunteers must not be given access to files, and they need to be warned that even the names of the people who are admitted is private information. A supervisor may not ask a counselor what was said at an AA meeting. Group therapy leaders must spell out the explicit obligation of confidentiality to all the group members, including therapists. Visitors, too, can present a problem if maybe a staff member wants to invite someone to stay for a meal. They could be people that are unable to resist gossiping about who they see. And then we have the U.S. government that's issued strict, detailed regulations on confidentiality of chemical dependency treatment records. These rules are more strict than those that cover other healthcare providers. So, for instance, while the presence of a particular person as a patient in a general hospital may be public knowledge, the diagnosis and other details remain confidential. But the very fact that a person is a patient in a treatment facility for chemical dependency is itself a diagnosis, so it cannot be revealed without express written consent. Nor can it be denied, because that could suggest that an individual has been a patient, but has since left the facility. So we can only answer, federal law forbids me to say anything. So the usual signed consent for the disclosure of information to other agencies or professionals isn't going to suffice here. It needs to specify to whom the disclosure will be made and set a time limit. Even the disclosure of this authorized information to another agency without explicit consent is forbidden. Federal rules allow the courts to authorize disclosure of confidential information, but this only removes the prohibition and does not require disclosure. So they can say, okay, we've removed the confidentiality from this, so you can tell us, but it doesn't require us to say anything. We have the responsibility to protect that patient. Sometimes a third-party payer insists on seeing records in order to approve that medical care is necessary and hence reimbursable. This is an especially difficult situation. An ethically sound rule seems to be to release only the bare minimum of information necessary to get our patients their insurance coverage. And this is without revealing any private details that would possibly damage that patient's their reputation or jeopardize any further employment. Any information released for the purposes of third-party payment should be sent only to the medical director of the carrier or that director's department and not routed through the employer or the union or the patient's family. Also, all released information should be stamped with some sort of stamp that says confidential. Federal law prohibits further disclosure. So careful record keeping is going to be necessary to protect the rights of the patients and the colleagues. Under no circumstances should a chart be doctored when it's subpoenaed. And this goes even further in keeping files in a locked filing cabinet behind a door that has a lock on it. And some ethical codes say that you have to have 2 locked doors. So it needs to be in a room that has a door inside of a building that has a locking door. So we need to have 3 different locks on it, is basically what some of these ethical codes are saying. So it's going to be up to you to look at what your ethical codes provide for as far as confidentiality goes and record keeping and maintaining that and so forth. So problems involving conflict of laws, they're always difficult. Such was the situation when state laws required the reporting of child abuse, because that conflicted with the federal law that said that even the presence of the patient in a treatment facility is confidential. So Some people argued that equity places the right of the child not to be abused above the right of the abuser not to be identified as chemically dependent. Others said that confidentiality should take precedence, lest the parents with the alcohol or the drug problem be deterred from entering treatment for fear of losing their kids. So Congress, in 1986, they resolved this legal conflict. They passed Public Law 99-401 in August of 1986. It amends the Federal Law 42 U.S. Code SS 290-DD-3 and EE-3, and it adds the sentence, the prohibitions of this section do not apply to the reporting under state law of incidences of suspected child abuse or neglect to the appropriate state authorities. The new statute applies only to initial reports of child abuse or neglect and not to requests for additional information or records. According to Representative Don Edwards, which was chair of the Judicial Subcommittee on Civil and Constitutional Rights, it does not affect the subsection requiring a court order before records may be used to initiate or substantiate any criminal charges or to conduct any investigation of a patient. Bottom line here is we're only required to report it. We're not required to provide any more information beyond that. Also, the restriction on reporting is removed only when there is actual danger or harm to the child. Reporting merely because a parent has a problem with alcohol or other drugs, that's not permitted. The statute maintains maximum possible concern for confidentiality, even in cases involving the suspected child abuse. Procedure manuals must reflect this balance, and it should provide for notifying patients of this exception to their expected confidentiality rights. So with the legality aside, some ethical problems still remain. Requiring that all chemically dependent parents be reported would jeopardize a lot of treatment programs, because then word would spread through the community that just entering treatment would lead directly to child abuse investigation. Moreover, it would clog the child protective system and impede any efforts to combat any actual child abuse. When the attempts are made to jail pregnant addicts in an attempt to protect the fetus, some women could avoid all healthcare providers until the actual time of birth. Some even resort to abortion rather than facing jail. Some women have been prosecuted after delivery and their infants taken from them on the charge of delivering drugs to a minor through the umbilical cord. That was the case, Jackson v. Florida. In child abuse cases, our natural concern for the child may override our awareness of the rights of the accused. As a result, this presumption that one is innocent until proven guilty can easily yield to a presumption of guilt by mere accusation. And then this is further complicated by a growing trend of therapists suggesting repressed memories of child abuse through regression therapy, sometimes using guided imagery or hypnosis or massage. And all of these heighten suggestibility. The unreliability of some of these supposed memories is confirmed by the 50 cases of retraction reported by Berkeley psychologist Dr. Margaret Singer and by the research of Dr. Elizabeth Loftus, a University of Washington professor of psychology and law who's an expert on memory in testimony. Ethics and sound clinical practice both seem to support using the patient's own words in therapy, not adding to or embellishing his or her version of the incident. So it might be useful to put the issue of mandatory drug testing in historical perspective. So prior to the decriminalization efforts of the early 1970s, alcoholism and other drug dependencies were regarded as a crime. And jails were seen as the better place for drug dependent people than treatment centers. And then we learned that, putting people who were ill in cages didn't cure addiction any more than it cured any other diseases. So then fast forward to the early 1980s, the pendulum starts swinging again toward this massive law and order initiative. We have MAD, Mothers Against Drunk Driving, and SAD, which is Students Against Drunk Driving, and RID, Remove Intoxicated Drivers. and these other citizen groups that were organized around the problem of drunk driving, and they insisted that punishment and treatment each had a place and that limits had to be set. Parents and retailers who provided the alcohol to juveniles or people who are obviously intoxicated, they were held responsible along with the impaired driver. So parent groups increasingly espoused tough love, and they often emphasized the first of those two words. So, into this climate came reports of the government's failure to stem the use of heroin and marijuana and cocaine, and these headlines shouted about the crack epidemic. So, prior to the 1984 election, both the Republican and the Democratic parties vied to see which way they could take the hardest stance on drugs. And the candidates were publicly challenging each other to take urine tests. So massive amounts of money were spent on discovering drug users, but very little of that money was allocated for research or treatment. Some of it was earmarked for prevention, but a lot of it went for interdiction attempts and other law enforcement. Funding was more provided for more jail cells, more prosecutors, more border guards, more aircraft at the border, and certainly more pressure on Latin American countries whose economies are heavily dependent on the export of drugs to the United States. And then along with this, all of this came with an increasing demand for these urine tests to reveal any illicit drug use. Drugs and AIDS testing became a very routine thing in the military, and a number of employers began testing current and new employees. Wholesale testing of federal employees was urged, and these policymakers backed off only when the employees fought back. And that left the subject of drug testing to become hotly debated in the courts. So, what does all of this have to do with ethics? So, the argument is raised that if we have nothing to hide, why should we object to being tested? The Florida Medical Association expressed its willingness to have member physicians tested. Is this our business? Must we professionals take a position on this, on any of it? And if so, how? So, in my opinion, we should. So, if the nothing to hide argument were valid, then we shouldn't object to having someone read our mail or browse through our personal medical records or peek into our bedrooms. The preservation of the Bill of Rights and the privacy of every individual is worth more than the risk of failing to catch an individual who drinks or uses other drugs. These are not simple choices, and they have to be weighed carefully, not just made on impulse. Ingenious ways of beating the urine tests are multiplying, and clean urine is selling well where the tests are required. There is only one way to collect a urine specimen and to be certain of whose it is, and it's embarrassing for everybody concerned, but that's essential if we're to bother with urine testing at all. So, what does this do to the trust relationship that should be building between the patient and the counselor when the counselor is involved in this process? There are many problems with the testing mechanism itself as well. So, for instance, many of the testing programs ignore the most commonly used drug in America, which is alcohol. And then the available tests can be expensive or inaccurate, and sometimes both. Any positive results need to be confirmed using another type of test to ensure their accuracy. And then you have the problem of the chain of custody of the sample has to be protected to prevent any substitutions. And the results are further complicated because most of the tests indicate only use, not addiction. Clinical evaluation of the employee by an experienced addiction worker is still going to be necessary, since the distinctions between use, abuse, and addiction are going to require more expertise than is processed or that's possessed by most who see those test results. And there's little assurance that the use of these test results, even when they're accurate, are going to be limited to their stated purpose. Affordable treatment remains scarce, and there's little to prevent employers from using those test results to get rid of certain employees while keeping others. The employer should not terminate anybody until they've had an appropriate evaluation for an addictive disorder and the opportunity to participate in some sort of rehabilitation program. And what if the test is also used to detect pregnancy? What if a barbiturate is detected in the urine of an epileptic who needs it for a legitimate medical purpose, but who could be fired or lose a promotion if the reason for its use becomes known? So, the National Council on Alcoholism and Drug Dependency, NCADD, they issued a policy statement on mandatory testing in 1993, and that contains many cautions and limitations, concluding that a good employee assistance program is usually preferable. So again, we need to think this through and really take appropriate action here. This may include speaking out against random testing, as opposed to testing when there's evidence of impairment and a demonstrable effect on the job performance. But it might also include a personal refusal to be tested. So if refusers are few in number and the rest of us just meekly go along, it's going to be easy to claim that a person must be guilty because of that refusal. And if there's enough of us who object that are clearly unlikely to be using, that claim is going to be less plausible. The choice here is not limited to protecting privacy versus letting potentially dangerous employees pilot airplanes or operate heavy machinery. There's a variety of ways to monitor competence that don't require invasive medical tests. And even when we are secure in knowing our own aims, our values, and our ideals, the way in which they are applied remain endlessly varied. It's never easy, never static. The striving for progress, not perfection, doesn't end. It can lead to some of the most painful choices that we have to make, and also some of the most satisfying. So lastly, let's talk about HIV and AIDS. So we all know that a person caught in the web of addiction will often make thoughtless remarks or drive while impaired or get into domestic squabbles, if not actual violence. And they might participate in a variety of sexual activities that are impulsive or unplanned, often unwanted, and sometimes dangerous. So one woman summed up a lot of personal history by saying that one of the rewards of abstinence was waking up in the morning without having to ask, who are you and where are we? We live in an age of AIDS. Particularly here in Atlanta, where I'm at, the new rate of HIV cases is exponential. I heard it compared to Somalia, the rates in Somalia, and Atlanta has a higher new diagnosis rate of HIV than Somalia does, the whole country. So this disease has profoundly changed our society. AIDS is caused by the human immunodeficiency virus. It's not a lifestyle. The spread of AIDS and our survival depends on what we do. Unfortunately, its first victims in the US were the very people who are the favorite targets of the bigots: gay men, prostitutes, IV drug users, and Haitians. And there were others as well, but their numbers were much fewer, like people with hemophilia, those who received the HIV contaminated blood transfusions, infants born to mothers who were carrying the virus during pregnancy, and also heterosexuals. But a lot of the public managed to persuade itself that HIV infections and AIDS would not spread into the heterosexual community. So concern for those dying of AIDS was pretty minimal. And some even sat in judgment on its victims, and some, including a physician among them, said that this was God's punishment for their sexual orientation or their drug use. But we've seen changes. The changes have occurred. We know HIV infection is difficult to catch except through sexual contact or the use of contaminated needles that are contaminated with blood, or the transfusion of blood products. One doesn't get it from sharing a table or a toilet seat or a swimming pool. It's not spread by a group hug or even a kiss. It would take a gallon of saliva to even have amounts of the virus that could be detectable. So parents do more for their children's health and safety by using seatbelts properly or refraining from smoking around their kids than by becoming hysterical over whether or not a youngster with AIDS is in the same elementary school. Another major change is the knowledge that HIV infection and AIDS have now spread into the heterosexual community. HIV has arrived in every state and in every social class. The number of people who have the virus but who are not members of high risk groups grows steadily, particularly among young people. And this is going to continue. The groups now accounting for most of the new cases are addicts and their sexual partners, not homosexuals. And most of us who treat chemically dependent people are already treating people who have been infected with HIV. And some of us will discover that we too have been infected, although not by our patients. Some appear entirely well, and they may remain that way while carrying the virus and being capable of infecting others. A few of my patients have had AIDS, and there are many stages in between. So when there's a disaster, most people feel free to save themselves first. But traditionally, certain professionals have been expected to stay and help others. And these are going to include doctors and nurses, clergy, ship captains, firefighters, police, the military. And addiction counselors are still too new a profession to have much guided training or tradition. The very first people treating people with AIDS demonstrated really great courage. They cared for these patients before it was clear that the disease wasn't contagious through casual contact. And while other diseases like cancer or emphysema, they present complications in the treatment setting, AIDS presents a special challenge because more of our feelings about it than the problems it presents. We have to deal with these irrational fears of both the patients and our colleagues. Patients have been abruptly discharged from treatment because administrators feared that if their presence were known, other patients would leave or stay away, and the census might drop, and the money would be lost. This persists even though patients with HIV and AIDS are not dangerous to others. We know that usually there's a period of 10 years or more between the time a person's infected with HIV and then becomes ill with AIDS itself. And these are potentially good years of productive, sober, drug-free living when a person can benefit from treatment. If someone does have HIV or AIDS, we're faced with the same situation we face with many cancer patients. A patient whose comfort and physical condition can be improved, who will probably go through periods of seeming recovery, but whose time remains limited. Any dying person brings us face to face with our own morality and our limitations. Our time for dying will come, and we're powerless to cure, and we can only delay. So to make it worse, AIDS patients are often young, not elderly. So perhaps that knowledge that there will be an end to life is one of those major differences between ourselves and other animals, but it's not an easy knowledge to fully accept. So how tempting to rationalize that since a patient's days are numbered, we could better use our time and energy on other people. It's much harder to admit that we're uneasy. And sometimes we're at a loss for words and searching for an excuse to run away rather than to stand beside the patient and face together what's coming and do it without the use of drugs. When the fear of contagion has been laid to rest and the reality of a possible premature death is understood, there may remain another problem. If the patient is gay, some counselors who have not worked through their homophobia might shun the patient. Homosexuality isn't contagious either. Men or women secure in their sexual identity have nothing to fear and no need to attack. So if working with a gay man or lesbian is uncomfortable for a counselor, one of two roads can be followed here. Either work out the feelings or acknowledge the limitation and let someone else work with that person. It's difficult enough to have AIDS, to be gay or lesbian in the present social climate, or to admit to being an alcoholic or an addict. the last thing that a patient needs is to be counseled by someone who disapproves of what that patient is. And if we can't really accept and love, let's get out of the way and make room for those who can. So I want to talk to you a little bit about TASP, which is treatment as prevention. And this refers to taking HIV medicine to prevent sexual transmission of HIV. It's one of the most highly effective options for preventing HIV transmission. So people with HIV who take HIV medicine called antiretroviral therapy, or ART, as prescribed, and they get and they keep an undetectable viral load, which is a very low level of the HIV in the blood. And they can live long and healthy lives, and they will not transmit HIV to any HIV negative partners through sex. This is sometimes called undetectable or untransmittable, which they say undetectable equals untransmittable. So TASP works when a person with HIV takes that HIV medicine exactly as prescribed and has regular follow-up care, including routine viral load tests to ensure their viral load stays undetectable. And PrEP is a powerful prevention tool with the potential to benefit Americans who are most at risk for acquiring HIV. So not only do we have treatment as prevention to get the viral load undetectable, but we also have a new medication called PrEP that will, it's not 100%, but it has a very high likelihood of preventing a person from receiving or getting HIV if they do have sex with a partner that is HIV positive. It's not the only option. Additional high-impact HIV prevention strategies include antiretroviral treatment for the people living with HIV, correct and consistent use of condoms, interventions to engage and retain people in care and reduce risk behaviors, and then also access to drug treatment programs. And I know this is taboo, but sterile injection equipment for people who do inject drugs. This is what we call the harm reduction model. Give them clean needles so that they don't further harm themselves. And with about 40,000 HIV infections diagnosed every year, we must make the most of all available HIV prevention opportunities for those most at risk. So to accomplish these objectives, we need collaborative action. Providers are going to play that central role in increasing the awareness and the uptake of PrEP and these treatment as prevention medications.